Dr. Kim, so I think you may start to moderate this session. We can start the session now.
So I'm trying to Chengung National University for organize this second international conference of research and education center for bridging ASEAN mental health and psychiatry. Yes. This session I'm the chair and we have 4 speakers. First, Manit Sri Suparanan from Thailand. Second, Dr. Jan T. Tu Hoa from Vietnam. And third, Dr. Brihastami Savitri from Indonesia. And fourth, Dr. Ben Jalak Maniton from Thailand. So let's go to first speaker. I would like to introduce Dr. Manit Surapanan. He is professor of psychiatry of Department of Psychiatry, Faculty of Medicine, Chiang Mai University. He will talk about symptoms and other clinical features of depression in Asian patients. So please, Dr. Manit, this is your floor to start your presentation.
Okay, thank you, Dr. Kim. Everyone hear me, right? Dr.
Yes.
Wang, I sent my video to you last week. Shall we open the video for my presentation?
Okay, no problem. We
Yes.
will play your video.
Yes, please start my video. That's easier. After my video presentation, I would be happy to take any question from everyone. Dr. Wang, there is no sound.
Okay, we will replay it again.
Thank you. Presentation, I wish to other clinical features. Hello, everyone. I'm Manit Surapanan from Chiang Mai University Faculty of Medicine, Thailand. Before I start my presentation, I would like to thank the LIBAM committee for giving me an opportunity to give a talk on the topic of symptoms and other clinical features of depression in Asian patients. This slide shows the conflicts of interest of mine over the past 3 years. This is the outline of my presentation. I will include 3 issues. First, the prevalence of depression in Asia compared to Western countries. Second, depressive symptoms in Asian patients compared to those living in Western countries. Last, I will touch on the factor associated with common depressive symptoms in Asian patients. Based on the global burden of disease study in 2017, Asia shares about 58% of the daily loss due to depression in the world, which was about 2.5 million years living with disability. Of the daily loss due to depression in Asia, China and India share about 1/3 each. Now we start with the first issue of the prevalence rates of depression in Asia compared to Western countries. This study was carried out almost 20 years ago in 5 countries, including the US, Belgium, Japan, India, and China. The study focused on the prevalence rates of MDE. You can see that the lifetime and the 12-month prevalence rates of MDE in Japan and China and also India were much lower than those of the US and Belgium. A WHO report in 2017 showed the high prevalence of depression in the region of Africa and America. The lowest prevalence rate was in Western Pacific countries. Although this region also includes Australia and New Zealand, the population in 2 countries is just a fraction of Asian people. This data therefore imply the low prevalence rates of depression in Asia. This study includes many ethnic groups in the US. This slide shows only the data on Asian people. For each ethnic group, you can see that Asian-born Americans had lower prevalence rates of depression compared to the US-born American. This data appear to support the effect of environmental factors on the prevalence rates of depression in each ethnic group. The environmental factor may also include the experiences during the early years of life. In conclusion, Asian people seem to have a lower prevalence rate of depression than those living in Western countries. It is possible that ethnicity and or environmental factors play a role for the lower prevalence in Asian people. Now we move to the second issue of depressive symptoms in Asian patients compared to those in Western patients. Before I start presenting the finding on this matter, I wish to mention about a common statistical technique that we usually use for testing the difference between groups regarding the symptom frequency and or severity. The 2 bars on the left-hand side show the simple comparison of cognitive dysfunction in Thai men and women with MDD. Because women in this study had more severe depression, this group endorsed most depressive symptoms more frequently than men. This direct comparison, therefore, was not fair. For the differential item functioning or DIF, it compared the frequency and severity of a symptom between groups by adjusting the illness or disorder severity. There are many DIF techniques. Most techniques usually present 2 S-curves, like the one showing on the right-hand side. If the steps of these 2 curves are much different, It means that there is a difference between groups on the symptom frequency or severity. This is a community survey comparing the frequency of depressive symptoms between ethnic groups in the US among the 7 add-on symptoms of MDE. Asian Americans were more likely to have suicidality than white Americans. This study compared the PHQ-9 symptoms in primary care patients. It found that Chinese Americans had more severe symptoms of sleep and psychomotor problems, but less severe symptoms of appetite disturbance. This study compared the frequency of MDD symptoms between Koreans and Americans living in their own countries. Among the 9 MDE symptoms, depressed mood and thought of death were more common in the American group, but low energy and poor concentration were more common in the Korean group. This study compared the severity of 17 MDD symptoms between Korean and American outpatients with MDD. It found that depressed mood and feeling of punishment were more severe in American group, but suicidality and hypochondriasis were more severe in the Korean group. Because the findings are so diverse, we will focus only on the replicated findings. Compared to Western patients with MDD, Asian patients seem to have less severe depressed mood, but more suicidality. For the third issue of factors associated with common depressive symptoms in Asian patients, I will focus on 3 symptoms only. Those include insomnia, anxiety, and cognitive complaint. I chose these symptoms because they are relatively more severe in Asian patients with MDD. The data that supporting this claim will be shown in the following slide. Because many findings that I will present in this topic are drawn from this study, I will talk a little bit about the methodology of the SAT, the study on aspect of Asian depression. This study was carried out between 2008 and 2010. It is a cross-sectional study in 6 countries in Asia. The inclusion and exclusion criteria were shown on the right-hand side. We use many measures to rate the number of symptoms and clinical features of the sample. Based on the SAT data, depression and anhedonia were more severe in these participants. This should not be surprised because these 2 symptoms are the symptoms required for the diagnosis of MDD. However, we also found that anxiety, insomnia, and cognitive complaint were also more severe than others. For this issue, I will therefore focus on these 3 symptoms. Based on the SAT data, about 75% of the sample might meet the anxious distress subtype of the MDD, which is a new subtype of MDD in the DSM-5. We found that this subtype of MDD was associated with severe impaired functioning, severe insomnia, and severe depression. Another study in China also found that high anxiety in MDD patients was correlated with dysthymia, OCD, and suicide idea. A study in Korea in patients with MDD found that insomnia was associated with the advanced age, GI symptoms, severe anxiety, severe depression, and poor insight. In the SAT study, we found that 45% of our sample had severe insomnia. We also found that severe insomnia was associated with low education, severe depression, severe anxiety, and poor physical health. A study in Canada for cognitive complaint in 81% of depressed patients compared to only 14% of the control group. In our study of the SAT, we found memory and concentration complaints in about 82% of our sample. We also found that concentration complaint was associated with younger age, severe depression, severe disability, poor physical and mental health. It should be noted that concentration complaint is a subjective cognitive symptom. Recent findings suggest that subjective cognitive dysfunction is not correlated with objective cognitive dysfunction. It is possible that young patients with MDD concern more on their cognitive function, but their objective cognition may not be so impaired. The COGNAT study was carried out in 6 countries in Asia. This is another study in Asia, including Taiwan. Based on the PDQD, which measures subjective cognitive dysfunction, we found that subjective cognitive dysfunction was more severe in Southeast Asian patients compared to Taiwanese patients. Subjective cognitive dysfunction also associated with longer duration of depression, severe disability, and younger patients and severe depression. I wish to remind that younger patients have more severe subjective cognitive dysfunction. This is a replicated finding of the previous one. I wish to make a conclusion of the whole presentation of mine in this slide. Asian countries have lower prevalence rates of depression than Western countries. Ethnicity and or environmental factors may play a role for the lower prevalence of depression in Asian people. Compared to Western patients with MDD, Asian patients seem to have less severe depressed mood, but more suicidality. In Asian patients with MDD, insomnia is correlated with anxiety and depression, and cognitive complaints are more common in young patients. I wish to end my talk by expressing my thanks to my colleagues in the SAT and the COGNAT studies, and also thank you for your attention.
Good morning, ladies and gentlemen. Now I'm happy to attend.
So thank you very much, Dr. Manit Sri Surapanat, for your presentation. It's about discussion born people who live in Western country appear to have lower prevalence of depression than local people. Any question? I think after all 4 speakers, we will question if you have. So let's move to Dr. Chan Chi Tu Hoa. Dr. Chan Chi Tu Hoa is a professor of psychiatry or Department of Psychiatry, Hanoi Medical University, Hanoi, Vietnam. He talked about survey of depression in lung cancer patients in Trang Chieu Cancer Hospitals. So let's Dr. speak. It is your floor to start, please.
Okay, we will play the second presentation from Dr. Ha from Hanoi, Vietnam.
Good morning, ladies and gentlemen. Now I'm happy to attending online conference. I introduce myself. My name is Trần Thị Thu Hà. I will lecture in Hanoi Medical University and I work as a psychiatry in National Institute of Mental Health. I want to share my research that I did last year. Survey of depression following PQ-9 scale in patients with lung cancer in Tân Triều Cancer Hospital. My presentation has 6 parts. Introduction, literature review, subject and method, result and discussion, and conclusion. Introduction, lung cancer ranks first among all types of cancer in men. It is a leading cause of cancer death. Lung cancer has poor prognosis, it caused rapidly and high mortality rates. Patients have fears and disappointed after being diagnosed with lung cancer. Quality of life becomes worse after being operated, and side effects of treatment cause mental disorder. Depression in patients with lung cancer affects quality of life and it causes stress on caregivers. So I did this research with 2 objectives. The first, a survey prevalence of depression among patients with lung cancer at Tân Triều Cancer Hospital. The second, describe some factors associated with depression in patients with lung cancer at Tân Triều Cancer Hospital. Review of literature. As you know, depression is a common psychiatric disorder in community. Depression is more common in women, with the female-male ratio is 3:1. Depression can occur in all ages, more common in age from 25 to 44. Following to WHO, approximately 350 million people suffer from depression. In this slide, you see the prevalence of depression in the world. In Vietnam, we have about 4% of population suffer from depression. In Vietnam, we use ICD-10 in clinical, but in research, we use both ICD-10 and DSM-5. In this slide, there are characteristics of diagnosis depression syndrome. A psychological test for depression. There are many depression rating scales that have been validated and applied in Vietnam, such as BDI, Hamilton, DASH, GDS. Among them, the BDI and Hamilton are more commonly used. Hamilton is quite complicated. It takes at least 15 or 30 minutes to do, and clinicians must be trained. BDI is a self-assessment scale with a lower sensitivity than the Hamilton. PQ-9 were validated in 2 research in 2,000 patients at 8 primary care centers and 3,000 patients at 7 clinics. PQ-9 is a scale for early diagnosis of depressive disorder, assessing the severity of the disease and monitoring response to the treatment. Time to complete PQ-9 about is 7 or 8 minutes. Epidemiology of lung cancer. Can you see? You can see in Vietnam, the prevalence of lung cancer is the highest in the world. In 2012, in Vietnam, we had 125,000 new cases of lung cancer and 94,000 deaths from lung cancer. In 2018, the numbers of the new cases of lung cancer increased to 31%, and the number of the deaths from lung cancer increased to 20,000. In Vietnam, we have two classifications of lung cancer. The first classification is TNM, and the second is older classification in non-small cell lung cancer, including 1, 2, 3, and 4 states, and small cell lung cancer, including limited state and extensive state. Depression in lung cancer patients. Prevalence of depression in lung cancer is higher, more than 30%. Breast cancer is more than 9%, and colon cancer is 7%. Associated factor of depression in lung cancer, including gender, duration of disease, state of disease, symptom of comorbidity, and surgery or chemotherapy history. Depression in lung cancer patients. There are some results of other research by other authors. You can see in this slide. And method and procedure. The method study is a descriptive cross-section study. Sampling convenience SAM. We have 169% with lung cancer. We did research at Tân Cancer Hospital, analyze and process with SPSS 30. Research subject who have 169 lung cancer patients at Tân Cancer Hospital. Inclusion criteria. All patients have been diagnosed with lung cancer at least 2 weeks. No history of psychiatric disorder. No other cancer. Full information from medical records. Exclusion criteria. Patients also have other cancer, disorder of consciousness, and patients refuse to participate in survey. Some characteristics of participants. The number of the male suffering from lung cancer is 4 times higher than that female. The median age about 16. The youngest participant is 19 years old, and the oldest participant is 88 years old. The majority of participants come from rural area, more than 18%. 75% of participants have completed primary and secondary school. The participants with the diverse occupation, 56% are female, about 30% are worker, retired officer, and nearly 30% of the research participants are student freelancer. Most participants live with their families, and most didn't receive support from government. 90% of patients with lung cancer are not small cell. The prevalence of disease under 6 months accounted for the high risk rate, 84%. State of cancer according to TNM in a group of patients with non-small cell lung cancer is distributed in stage 1 to 4. The highest rate in stage 2B and 3B. Cancer patient is high risk with the rate 27% and 25% respectively. For patients with small cell lung cancer, 100% are in the extensive stage. Regarding comorbidity, nearly 70% of participants have a comorbidity with main internal disease. Most patients have no family history of cancer or mental illness. Level of depression. Patients with depression accounted for about 50%, and the proportion of the participants with severe depression were lower than the proportion of participants with mild depression. In particular, the percentage of participants with moderate and severe depression is 16. For severe depression rate is less than 3%. The proportion of patients with lung cancer showing depression, according to the PHQ-9 questionnaire, combined this account for 51.5%. My result is high. We explained due to the fact that majority of participants were newly diagnosed with lung cancer. 85% were diagnosed in last 6 months. Most patients are in the process of treatment in a hospital. According to a meta-analysis of over 100 studies, the patients are in the process of treatment with a high risk rate of depression. The prevalence of typical depression in our study is higher than other research results using the diagnosis scale DAS, CES, ICD-9. However, our research results are similar to those of other lung cancer patients using the SDS and HUDAS. Another finding in our study is that in the participants showing depressive symptoms on PHQ-9 scale, about 35% have suicidal ideas. This result is equivalent to other studies. Depression were higher among men than women. The difference were significant. In our study, the prevalence of depression in men was 65% and more common than for women at only 35%. However, in severity, women accounted for 80%, while men accounted for only 25%. The proportion of men in our study is higher than women, which may explain the prevalence of depression rate more commonly in men, but we found that several is more common than female. With the above ratio, the hypothesis that men are more popular than women is because the number of men in the study is many times higher than for women, or through inverted logistic regression analysis also showed that women are at risk depression is higher than men. In general, men who are at risk of depression will still be less than women. In my study, we have 35% of the patients with suicidal ideas. There was a significant difference in the depression with suicidal idea and no suicidal ideas. Although for the non-depression, 100% of the participants have no suicidal thought. The opposite was true for the depression level of moderate and severe non-small cell lung cancer in the extensive state is at higher risk than those in the limited state, who have just had cancer patients with other medication conditions have a higher risk of depression than those who don't have combination disease. Patients with medication and cancer combination have OR 2.57 and P 0.006. In family group with a history of cancer, the risk of depression is higher than the family group no history of cancer. And conclusion: prevalence of depression in lung cancer. The prevalence of depression in lung cancer kept 1 and 10 with PHQ-9 is 51.48. The prevalence of suicidal idea 35%. Some factors associated with depression in patients with lung cancer. 3 factors associated with depression in lung cancer: gender, comorbidity, and history of cancer in family. In particular, the risk in women is 4 times higher than men. Patients with combined medication conditions were 2.4 times more likely to be depressed, and those with family history of cancer were 4 times more likely to be depressed than others. Recommendation: using the PHQ-9 scale for the patient diagnosed with lung cancer. Healthcare facility for cancer patients, especially lung cancer patients, need mental health care support of the patient. Patient with lung cancer is associated with other medication conditions and families' history of cancer need more attention. That's my research. That's my presentation. Thank you for attention.
Okay, thank you very much, Dr. T. Tu Hua, for your interesting presentation. As informed by organizer, the Dr. Brihastami, she has the problem with technical internet, so I would request Dr. Benchalak Maniton to be a speaker for this symposium. So, Dr. Benchalak, you are ready for this speaking?
Please open the video that I have attached with the email.
Okay, we will play your video.
I'm Professor Benchalak Maniton. I'm working in Consultation Liaison Psychiatry, Department of Psychiatry, Faculty of Medicine, Chiang Mai University, Thailand. Thank you, Rebam, for setting the teleconference during the COVID-19 pandemic outbreak. This is a new normal situation to have a meeting together. Thank you. I think everyone used to see cancer patients. Today, I would like to share my experience about depression in lung cancer. Let's start with all cancer. As we know that depressive symptoms are commonly reported in patients with cancer. However, those symptoms in such patients could occur with a broad range from normal sadness up to major depressive disorder. Many primary doctors think that patients who have cancer just present with a normal reaction of crying or sadness, but some of these patients need to be evaluated and treated for depression. For many research, we found that prevalent rate of depression in cancer will vary. For example, major depression rank from 0% to 38%. Depression spectrum syndrome vary from 0 to 58%. That may come from many factors. For example, the conceptualization of depression. The definition applied to categorize depression, the instruments used to assess depression, or the study population. These are the instruments that all of you have been known. The mini international neuropsychiatric interview, the big anxiety inventory, the hospital anxiety depression scale, and the patient health questionnaire. This scale were used in psychiatric clinic and research. These scales are also used to assess depression in lung cancer. The rate of prevalence of depressive episodes in the lung cancer patients was vary from 12 to 70 depend on biopsychosocial risk factors such as impairment of function, fatigue, and severity of depression. That means each study has different cutoff point. The lower cutoff point for the patient screening, the higher prevalent rate of depression. The higher cutoff point, the lower prevalent rate of depression. Although risk factors associated with developing in depression for cancer patients has been interesting, there have been a limited study in patients with lung cancer. In addition, previous studies have been conducted in various countries. Consequently, their outcome may be limited to generalize in different populations. My study conducted in the northern parts of Thailand, there is a higher prevalent rate of lung cancer there. The prevalence is higher than the other parts of the country. This may be due to burning forests every year. I'm working in consultation liaison psychiatry unit for 20 years. I'm taking care of patients in general hospital. So I have been studying this kind of research, prevalent and associated factor of depressive disorder in lung cancer patients receive chemotherapy at the one-day chemotherapy units, a cross-sectional study. I plan to examine the prevalence of depressive disorder in the lung cancer patient who plan to receive chemotherapy. I plan to assess the associated factor with depression in such patients. I use a cross-sectional study at one-day chemotherapy unit at a university hospital in the northern parts of Thailand. Patients with all stages of lung cancer who plan to receive chemotherapy were eligible for this study. Basic clinical characteristic data of included patients were correct. We used the mini international neuropsychiatric interview Thai version and the patient health questionnaire to assess depression. Based on a total of 138 patients with all stages of lung cancer at one-day chemotherapy units from February to October 2015, 135 patients were eligible for analyzing in this study. Based on the mini international neuropsychiatric interview and PHQ-9, we found that about 16% of them were defined as having depression. Depression ranked from minimal depression, mild depression, moderate depression, and severe depression. From the study also found that about 8% of patients had only neurovegetative symptoms without depression. The definition of neurovegetative symptom, that means the disturbance of a person's function necessary to maintain life, or vegetative function or physical manifestation, commonly seen in mood disorder and are part of the diagnostic criteria for depression, but also appear in other conditions, for example, in lung cancer. Vegetative symptoms in a patient with typical depression include weight loss and anorexia, insomnia, fatigue, and low energy. All of these symptoms also found in cancer patients. After my study, we found that about 8% of patients have only neurovegetative symptoms without signs of depression, such as suicide or depressed mood. We analyze the factors that's associated with depression in lung cancer by using binary regression analysis. We found that patients who have economic problems, who have brain metastasis, who was chemotherapy naive, that means patients who have not been treated by chemotherapy yet. That means they are waiting for the treatment of lung cancer. And the patients who have higher score in Shatter fatigue scale. All of these patients were significantly associated to a higher risk of depressive disorder. Let's see each factor. The first factor, economic problem. We found that dramatic improvement in lung cancer outcome can be attributed to recent advance in novel target therapy and immunotherapy. As the treatment paradigm for lung cancer evolved, concern about the rising cost of this novel therapeutic had become a global dilemma. Costs of treatment are more expensive than before. Economic problem. Most of these patients lost their job, so they have no work. They need caregiver. They have to pay for medication and travel expense. All of this use a lot of money. The second factor, brain metastasis. See a lung patient who have brain metastasis that have brain inflammation, brain pathology, and brain pathway change. This can cause depression directly. Or moreover, complication of tumor, for example, headache, speech problem, peripheral weakness, etc. This can cause depression. If they have brain metastasis, they have to receive intensive treatment that also cause a lot of side effects and can cause depression. The third factor, chemotherapy naive. Why chemotherapy naive feel depressed more? We can explain that these patients are waiting for the treatment. They usually have complications from local cancer, example, SVC obstruction, rib erosion, recurrent laryngeal nerve palsy, etc. This can cause pain and leading to depression. But the patient who receive chemotherapy will relieve this tumor complication, so they have lower risk of depression. The last factor, shadow fatigue scale or fatigue scale. The questionnaire used in this study, we asked about fatigue. For example, do you have problem with tiredness? Do you need to rest more? If the patient has higher score, that means it has high shadow fatigue scale. Shadow fatigue scale If the patient who have fatigue, we can explain that these patients have peripheral inflammation activated brain cytokine signaling which result in sickness behavior. These factors can cause depression. In conclusion, according to those findings, depression disorder is commonly found in patients with lung cancer. Additionally, the patient with economic problem, brain metastasis, chemotherapy naive, and fatigue have increased risk of depressive disorder. As a psychiatrist, we should join with the team and tell them to treat all of the biopsychosocial aspects to improve depression and the quality of life of our patients. Please share your experience. Thank you very much.
So thank you very much, Dr. Benjalap Maniton, for your interesting presentation, both speaking on depression related to the cancer from Vietnam and Thailand. I think it's very important. As you mentioned about biopsychosocial risks that lead to more severe depression, I think it's all patients with cancer mostly suffer from at least one of mental health problems, not only depression, but anxiety. Some lead to severe mental disorder like psychotic disorder, I think, yes. So because we don't have more time, I think let's move to Dr. Brihastami Savitri from Indonesia. She is professor of psychiatry department of Faculty of Medicine from University Airlangga. So Dr. Brihastami will talk about challenge and result in raising awareness on suicide prevention in Surabaya as a report. So please, Dr. Brihastami, this is your floor, and then start your presentation. Yeah.
Can you hear my voice?
Yes.
Okay, thank you.
Yes.
First of all, I would like to thank the committee and also the chair for the opportunity to share the challenges and results in raising awareness on suicide prevention in Surabaya. A report from me, Brihastami Savitri. I'm a lecturer in Department of Psychiatry in Universitas Airlangga, which is located in Surabaya, the eastern part of Java in Indonesia. So as we know, throughout the global, in the global situation, there are 800,000 people died each year by suicide, which means at the age of 15 to 29 years, and an estimated of 71,000 deaths from suicide are found in adolescents. Sadly, the higher number of suicide are found in developing and third world countries, which is included in Indonesia. From the Global Burden of Disease report, it says that the higher rates of suicide mortality in few countries influence the regional averages of global burden of disease region, particularly in Indonesia and Southeast Asia. But sadly, the number of actual suicide deaths tend to be higher. Because Indonesia doesn't have a formal suicide death registry system, and I will tell you more about that later. From the report from the WHO in 2014, we found that there are 9,106 deaths caused by suicide in 2012. If we search the number, actually Indonesia is considered as the lower number of suicide between countries in the world. But as I mentioned before, it's probably only the tip of the iceberg. Why? Because there are major barriers for seeking help for people with suicidal thought. As we know, in general, stigma surrounding mental health are very thick because it correlates with the social and economic status from the people. And also, if there's a person who completed suicide, most of the time, their family doesn't report it as a suicide. Like even from the prominent people in the country, when their families are completed suicide, most of them doesn't acknowledge it as being a suicide because the heavy stigma doesn't only surround the person who died because of the suicide, but also because of the family. Family has the burden, being blamed, etc. So that's why most of the family kept it as a secret. In general, the social acceptance of help-seeking behavior is also very low because people are considered weak when they when they're asking for help or seeking for help regarding mental illness. And also, there are several cultural influences, such as the gender differences. For example, when male are seeking for help, they are considered like they are weaker than women. And sometimes if women try to seek for help, they don't have the authority to do so. They need permission from their family, they need permission from their spouse, etc. So it becomes a barrier for seeking help. And also the availability and access to mental health institution is not same in every region in Indonesia. For some part of Indonesia, you have to take a boat, a plane, just to see a psychiatrist or a psychologist. So it's not easy, and it's not the same opportunity for everybody because as we know, we have many islands, and also we have many mountains. So in geographical reasons, it becomes a barrier in seeking help for people with suicidal thoughts. And there are also religious views, as we know that some religion consider it to be sinful to take your own life. So that's why when people have suicidal thought, it becomes harder for them to admit it, to even admit it that they have thought about suicide. And it even trigger shame. It's a sad thing that just a couple of days ago, I have a patient that come to me and ask for my forgiveness because he has come across a suicidal thought a few years ago, and he asked for my apology. And I think that's very sad because nobody should ask for apologize for having suicidal thought. So that's also some personal views about suicide, which is might be different for everybody. And also the health system. I think it will be very beneficial for people in Indonesia if we can improve our health system, especially in mental health system. First of all, we have universal coverage, but sadly, if a person are committed to the ER because of they have a suicide attempt, the universal coverage is automatically aborted. They don't really have the insurance anymore. they don't cover for your health cost. Even though not only for the mental medication, but sometimes if you need help with your intoxication or your because when you cut your wrist, etc., they don't cover for it because you have a suicidal attempt, and because it says that you inflicted it by your own, which is so sad because Indonesia has already adopted the WHO certification, which should regard the inclusiveness for everybody and doesn't discriminate against mental health. As we know that suicide attempt occurred often with people with depression. So that also make people doesn't have adequate medication when they already attempted suicide because they don't have enough money to follow up with the procedures. And so sometimes the doctors feels very sorry for the patient, and in order for the patient to get adequate medication for their suicide attempt, the doctor doesn't report it as a suicide attempt, which is not a good thing, I guess, because in that way we don't have a real data on how many suicide attempts that it has been happening in Indonesia. And also I think the hotline system for people who experience suicidal thought can be improved because we do have and develop some of the hotline, but not really accessible like 24 hours a day and not for everybody. So it can be improved for a better health system for all Indonesian people. So these are some of the initiatives that we began last year. We started the first Surabaya Suicide Update in 2019, which consisted several events. One of them are the workshops and also symposium. The workshop is attended by almost 100 doctors, physicians, psychiatrists, psychologists, and also other mental health worker. And the symposium was attended by 177 people throughout Indonesia. Some of them are influencers as well. Some of them are came from different islands in Indonesia. Prof. Pauline was a speaker there. And he also shared with us how to raise more awareness for suicide prevention. Other things that we did last year was having a talk show on the mall as well. We collaborate with different communities, such as Into the Lights. We collaborate with yoga communities, so they can have more awareness on suicide attempts. So why we choose the mall? Because like some of the people who are experiencing suicidal ideation, most of them doesn't come to your practice. Most of them are everyday people. So we don't only wait in the hospital, but we go to the community as well. We also set up several booths. We call it Talk Corner. So for people who have difficulties in assessing mental health, like a psychiatrist or psychologist, they can talk over there. They can share, and then our residents and also our psychiatrists can give them counseling and give them advices on what to do next. We also distributed brochures, not only in Surabaya, but also across regions around Surabaya. We collaborate with physicians and also psychiatrists around Surabaya to distribute it. As we know that the medical societies has higher risk for suicide. So that's why we also reach for the medical societies, like other specialties, because some of the stigma sometimes come from other physicians as well, as we are aware, even though they are struggling as well with mental health. They are the ones who have higher risk, but they also have the bigger barriers, personal barriers to seek for help. So we reach out for them as well. So there are many people who came to the Suicide Prevention Day when we held a vigil. Like in every event, we try to include survivors of suicide attempt. They were sharing their experience and their how they overcome their suicide ideas and suicide ideation, and also their mental illnesses. But we try to put it in a more positive way. Like, we don't try to glorify suicide or normalize suicide, but rather we normalize talking about suicide attempt or suicide ideation, so people would have less barrier in talking about their suicidal feelings. So some of the survivors, they read out poems, and also they play guitars and etc. So we collaborate with the survivors as well. We are very glad that there are plenty of press coverage that can reach much further people throughout Surabaya, East Java, and also throughout Indonesia. That is one thing that we are thankful, starting from the printed media and also the online media, and also the television station, and also the radios. This is, for example, there are several coverage. Okay, so we are happy with the result, but as we know, that is not the end. We have still a lot of things to do. We were planning for this year, for the 2020, we have the second Surabaya Suicide update. But because of the COVID, maybe there are several adjustments. And also we are planning to do a workshop for press to help them report suicide better, because most of the time they don't really aware about the guidelines in reporting for suicide, for a completed suicide, which can cause copycat suicide, and also further stigma surrounding suicide attempt. And we are planning also for creating ambassadors for suicide prevention, which may include like influencers during the from the social media, and also maybe from the younger generation, from the high school student, or the or after high school students. So for the students, so that is something that we are thinking about in order to reach younger generation, as we know that they do have higher risk, and they probably listen more to their fellow young influencers. And we're also looking for more collaboration with communities to have a better registry for suicide attempt and suicide, completed suicide, to have a better data, to have more data. And we also have we are planning to do more collaboration, as we know, as our previous experiences, there are several companies from the CSRs, and also that are concerned about suicide, and that we can reach out through them as well, and we can collaborate more with companies to raise awareness for their workers as well. We're trying to do more initiatives on the in raising suicide prevention awareness, and we also looking for more collaboration like inside and outside the country for doing researches regarding suicide attempt and suicide prevention. And most of all, we are eager to do advocacy. I think that is the biggest goal that we need to do, reaching out to the government as well to improve the mental health system and to improve the, including the universal coverage system, to include all of the citizens, regardless their mental health status. I think that's all for my presentation. I am looking forward for your input as well to make us improve better, to give us opportunity to do better in the future. As we all said to everybody who are needing help, especially regarding their mental health issue, you are worth my time. So thank you very much for being kind to me, for making me worth your time. You can contact me with for my email address for future discussion as well, if you'd like. Okay, thank you very much. That's all for now.
Thank you very much, Dr. Brihastami, for your interesting presentation about suicide prevention. Yes, this is topic very important, even Cambodia. Suicide patients stigmatized not only the family, but also with the society. And social media, so very low knowledge on how to prevent suicide and talking about suicide. So because we have more 5 minutes, so I thank to Dr. Manit Sri Susapanon from Chiang Mai University and Dr. Benchalak Manethon also from Chiang Mai University, Dr. Chanti Tuhua from Hanoi Medical University, and Dr. Brihastami for your interesting presentation. So I think in this floor we have some participants also view our session. So maybe we have some 2 more questions. Any participant want to ask our 4 speakers, please, before we closing the session?
Hello. Can everyone hear me?
Yes, I can.
Yes.
Okay. Okay. I'm Dr. Lu from Taiwan, and I'm also the international collaboration in this program. I'm interested about the 2 topics talking about depression in cancer patient. I think the 2 speakers is Dr. Har and Dr. Sawitri, right? So I have one question. How do you think about the depressive symptom in first diagnosis cancer patient and the recurrent cancer patient?
Please, Dr. Benchalak, you have any comment to the Lu questions?
Yeah.
Can you repeat again? Because the sound is not clear.
Okay. My question is, how do you think about the depressive symptom in first diagnosis cancer patient or recurrent cancer patient? Do you think the 2 type of cancer patient have more opportunity to get major depressive disorder?
You mean that the risk of depression in cancer patient and the risk of depression in recurrent cancer patient like that?
Yes, the first diagnosis cancer patient and the recurrent cancer patient. Yes.
Yes, I think it seems to be most likely to happen depressive disorder in both types of patient. For example, it's like a bad news for the patient who know that they become cancer. So the first group of patients usually found that we can find that they also has adjustment disorder first. If they cannot adjust with cancer, then adjustment disorder can develop to depressive disorder. And for the second group, recurrent cancer patient, they think most of them think that they are happy, they are free from cancer. But if they receive the bad news that the cancer come back again, I found that some of them feel depressed again. Yes, because the body have been changed again. They know the prognosis and they know that the cancer come back. They have to fight with chemotherapy or surgery or anything. So both group of patients seem to have problem with depression. Yes, I found the experience from my patient like that. Yes.
Okay, and I'm curious about your research that you said some symptom of fatigue have
Yes.
if patient have fatigue syndrome, they have more risk to get the depressive symptoms. So how do you differentiate that the fatigue symptom is related to the side effects of chemotherapy?
Oh, for my research, patients who receive chemotherapy at one day chemotherapy clinic at that time. So they receive chemotherapy, but some of them finish the course of chemotherapy and they go home to stay at home resting for a month or anything like that. So I think that it depends on the circle and the time of chemotherapy. If the patient have just received chemotherapy and feel fatigue, that's what comes from side effect. But some patients have been received chemotherapy for a month and return home and still feel fatigue. I think maybe it's not a cause of medication, maybe come from the cancer disease or maybe come from depression. However, it's just like a combination from biopsychosocial because this group of patients has a weak body, weak mind, and weak support from family. I think it's very difficult to differentiate each symptom. I think we should take care all of the aspects together. If the patient have depression, the cause of depression may be come from their body illness, their mind, or their support. So I think we should combine all of these things and treat on of these things together. Yeah.
Thank you. I want to ask some question to Dr. Brihastama Savitri, right? Okay, because some of my work is responsible for the suicide prevention in hospital, general hospital. So how do you think about general or overall screening in all the hospitalized patients? Do you think it's a good way to do the suicide prevention in the general hospital?
Yes, I do believe that is also a requirement because some accreditation actually require that we have training for suicide risk for patient, uh, especially the inpatient for inpatient patients. So for the outpatient, I think we we have just mostly do it in the psychiatric outpatient, but for the inpatient, we have a screening, just several questions to risk their suicide risk. That is required through the accreditation as well. I hope that is sufficient.
Yes. Because we just do the overall screening in all the hospitalized patients, but there is some difficulty is that because how do you think the screening scale used in the suicide prevention, is there some useful tool, some brief questionnaire can do the overall suicidal screening for the risk?
Yeah, I think there are several tools that are useful, but I believe that we can also adopt it to our culture as well, because as we know that there are several cultural barriers in talking about suicide ideas, so we have to be very careful with that, and we have to be flexible in asking about the suicide ideas that and also previous attempt that they have experienced before. So we can adopt it from the international. There are several I think that you can find, and also be flexible in order to adopt it, and we can like do more validation and also reliability studies as well to make sure that it's suitable for your population. Maybe we can talk more about that. I'm interested to collaborate more with you, Dr. Lu, in assessing those as well. Thank you.
Okay, maybe I can send some information or my experience in the suicide prevention in my hospital by the email, because I'm still very new in this period in this domain. Yes, thank you for your sharing.
So any more question from our participant? I think we also start a bit late, so now 5 minutes over our session. Any participant have questions? One more question, I see. Especially the Professor Wang Jingji, the organizer. Do you have any comment related to this session? Last comment.
Doctor, can you say Miss Wang? Dr. Kim? Dr. Kim, are you still there?
Yes.
Okay. Dr. Wang is it's just a computer. So I'm a staff member for this symposium. Yes. Dr. Wang is the name of the computer. So Dr. Kim, I think because the limitation of time, is the symposium night maybe could be closed, and I think if there are still others have some question, maybe we can ask by the email. Dr. Kim? Dr. Kim, are you there?
Yes. You do close the session, that's okay, Dr. Lu?
Yes. Yes, I think we have a wonderful talk, and I think there's still some questions, so we can if we have any question, we can discuss by the email.
So thank you very much for your all four speakers for your presentation. So we should close this session, symposium 9.
Okay, and I have some announcement here because there is some furtherly we have some another international conference maybe in the August, but the actual date is not confirmed. So every participant, you can receive your email. Currently, we will ask the available day for you to participate to another online conference in the August. Yes, so thank you everyone for your participation, and maybe see all you in August. Thank you.
Okay.
Bye.
Okay. Thank you. Bye bye.
Bye.